So, my name is Ognjen Stevanovic, like Dr. Oliver said. We'll be talking about a hip here, so femoroacetabular impingement. I don't have any disclosures. This is a outline of the talk. We're going to talk about this basic anatomy of what FAI is, what types of patients kind of come to clinic with this issue, what the history is, what the x-rays and the imaging looks like, and then briefly go over the treatment as well. And so the basic anatomy of FAI, essentially there's a cam and a pincer deformity. So up in the upper left corner you can see, what a normal relation between a cup and the femur looks like. In the upper right corner is the cam deformity, where there's just a deformity on the femoral side that can cause the impingement. Lower left corner is the pincer deformity, which can either be from the cup being too deep or the anterior posterior walls of the acetabulum kind of protruding, and then in the lower right corner you can have a mixture of these. This is a nice animation here that should work. There you go. And so this is a pincer deformity where as the hip flexes, it can essentially kind of crush the labrum. So there's a difference in the pathology of the labrum and kind of what this looks like when they're evaluated arthroscopically. And in most cases with this, the labrum is not repairable, and oftentimes this leads to necessity to reconstruct the labrum itself. But you can kind of see how it's directly in the line of impact there, and it just basically gets crushed. This is the cam deformity that was supposed to start. Let's see. Maybe. There you go. And so the cam deformity, you can see this bump here on the femoral side. And here, it's interestingly, the damage happens at the contralabral junction. So the labrum itself stays relatively preserved. And oftentimes, again, arthroscopically, once you come in and you evaluate these are repairable defects. And there is some separation of the cartilage as well. So, and again, here you can see as this hip flexes and it goes into that internal rotation position, you can see how that cartilage gets delaminated. So the basic kind of classification of femoroacetabular impingement, like I said, can be on the femoral side, it can be on the acetabular side, and generally this can be because the socket is too deep in cases of coxa profunda or protrusio acetabuli, but it could also be from the focal rotation of the acetabulum itself, the version, and then the size of the wall itself. On the other side, with the cam deformity, again, this could be from a typical bump, like we showed, that it could be from the cam deformity on the femur, but it could also be from the morphological abnormalities and the rotational abnormalities that the patient can have, such as femoral retrotorsion if the neck shaft angle is too high or too low, like in coxa vera. And so the classic three populations is that the cam deformity usually is a male that's in his 30s and is pretty stiff. A little bit older female patients, they do show up with mixed deformity as well. And then the other type of patient that typically comes in that has hip pain is a teenage hyperlax female, and this is usually the case of dysplasia and instability, as you can see in this X-ray there with the clear uncoverage of the femoral head and the upsloping sourcile. When it comes to clinical evaluation, just like anything with orthopedics, this needs to be systematic, and you want to cover all the bases, and you want to do a very careful evaluation of your patient to come down to the appropriate diagnosis. So typically we want to know what the injury history, whether there was an injury, what was the clinical exam, and again, systematic evaluation of the radiographs. And then typically you want to group these into two buckets, whether it's intra-articular pathology or extra-articular pattern. And so if the patient is coming from the joint, patients are typically complaining, they say that they make a C sign, we call it. So they put their hand like this and they just grab their hip on the side and it kind of wraps around. Very often the joint pain is in the groin, and it's very rarely a buttock pain. And so if patients do present like that, then you have to think about that it could be something else, whether it's a back issue, or if the pain is in the front, you can, this can be from hernias or genitourinary or gynecologic problems, pubalgia, athletic hernias and so on. And so again, if it's an intra-articular diagnosis, if you suspect that, there's typically a C sign. There's a loss of range of motion. This is usually asymmetric between the two sides. The provocative test, obviously, the intra-articular provocative test would be positive, and the extra-articular one would be negative. And the radiographic findings would clearly support this. And on the other end, if it's an extra-articular, there would be either a pelvic or lumbar or radiculopathic type of pain. The hip range of motion would be symmetric. There would be selective muscle weakness and dysfunction. It wouldn't be type of a global type of issue. And then the radiographic findings, would not be indicated, would not be, pointing towards this being an intra-articular issue. And so what are these radiographic findings? Typically when we get plain x-rays, we immediately can kind of see whether this is osteoarthritis, whether it's a dysplasia, is it an impingement, or is there a fracture as well? And so for me, I start with the AP pelvis, and I kind of in a systematic way start, going away from the hip initially. So I look at the lumbar spine, whether there's any arthropathy in that area, is there a leg length discrepancy or a pelvic tilt. And this is typically a dynamic leg length discrepancy rather than something that we see in arthritis. And then once I rule that out, then I look at the joint itself and evaluate it in more detail. And typical joint space is about 4 to 6 millimeters, although normal joint can be even less than that, but it does need to be congruent on a centrolateral and inferior view that you can see on the false profile. And so the next thing I look at is how well the femur is covered, and this is done by looking at the center edge angle. And it's an angle between the vertical line that goes through the center of the femoral head and another line that touches on the most lateral aspect of the sourcile, which is the weight-bearing area. And so this, in this case here, you can see that this is a dysplastic hip. There's quite a bit of a uncoverage of the femoral head, and there's an upsloping sourcile. And then on the other end of that spectrum, this is obviously a pincer type of lesion. Acetabular version is also very important to evaluate. This is more in full detail. It's evaluated on a CT scan, but even on the plain x-rays, you can kind of tell here that there's a global retroversion of the cups on both sides. And we can see that because there's a crossover sign, which is the, and you can kind of see those two lines kind of intersecting, and that's basically that the anterior and posterior walls cross over. That shouldn't happen. You should not see that in a normal hip. And the other telltale sign here is that the ischial spine in the back, you can also see it, so this kind of tells me that this is a globally retroverted socket. And the version itself is calculated in this manner, where the sagittal plane line is taken, and the angle is measured from that line to the line that touches the anterior and posterior wall, as you can see here. On the other end, the CAM evaluation is measured by using the alpha angle. And so that's the angle between the center of the femoral neck, and then this perfect circle around the head is made, and then the second line goes to anterolateral head and neck junction. And so anything over 45, 50 degrees can be indicative of impingement, although all the other measurements and the clinical exam need to be taken into account, because oftentimes you can have impingement and dysplasia at the same time. And I'll get to that in a little bit with some of the software that helps us kind of evaluate that in full detail. And so here's obviously a femur with a CAM deformity. So we make that perfect circle around the head, and then we can kind of see whatever sticks out on that side. That's the CAM bump that would typically need to be addressed intraoperatively. When you get an MRI, typically anybody with a limp, especially a female with a limp that's active, that's an athlete, is indicated for an MRI, because the FAI does not cause antalgia. So you have to think about, if this is a stress fracture, is it an AVN, is there some kind of other intra-articular pathology. We also get MRIs if there's a failure of non-operative treatment, or if there's an obviously acute injury. The CAM triad that we see on the MRI typically consists of a head and neck junction abnormality, as you can see up there, and there's that chondral separation in that area in addition to the actual labral tear. The one thing to keep in mind is that a lot of people walk around with labral tears, that doesn't mean that they need to be fixed. So you need to make sure that the pain is coming from the tear, and that's actually coming from inside the joint rather than just automatically, signing people up for surgery just because they have a tear. How do you treat this? FAI responds really well to physical therapy. However, arthroscopy is very beneficial and actually provides more relief than physical therapy alone. And these are the two studies that demonstrate that. The first one is a landmark study from UK where they had 350 patients, and they were enrolled in personalized physical therapy, and as well as the other group was hip arthroscopy. And while they both improved, there was greater improvement with hip arthroscopy. And the second study is from UK. There was less patients, however, they did come to the same conclusions. When we're repairing we go to repair the labrum, it isn't just putting stitches in and wrapping it up and getting out of there. You have to recreate this suction seal. So this is very, very important. You can see here with this video from Dr. Chawla from Rush, how much force this labrum creates here. This acts like a suction seal and actually significantly provides a distractive resistance. And even with the labral tear, Dr. Philippon from Vail has done studies where he demonstrated that just a simple tear in the labrum can decrease this distractive force by 60%. So this is critical in the OR for this to be done appropriately. So hip arthroscopy is very difficult, and so arguably most difficult orthopedic technique. And so we need all the help that we can get. And so for patients to do well, the indications need to be appropriate. There needs to be meticulous, planning, and you should never go into the operating room without a planned resection and what you're going to do. And this is reliant on how the patients are going to do, if the outcomes are going to be optimal if that plan is executed. And so this is, I'm going to talk about a hip map, which is a Stryker product that allows you to preoperatively plan and accomplish these goals. And it does this with the 3D interactive models where you can understand what the deformity is and what you need to address. And there are heat maps all around, and you can kind of rotate this. And you can definitely see, from multiple angles. There's also graphical comparison to reference values that are automatically calculated for you, and there's also self-education pamphlets here. And so this is kind of what this looks like. You can, once you send the CT into Stryker, they kind of recreate this for you, and you can kind of move this around however you want it in three-dimensional interface here. You can really know where you need to shave things out, because if you don't address the KIM deformity in an appropriate way, you can cause a lot of problems, either AVN or fracture, or if you don't resect enough. That's the #1 reason for failure of arthroscopic surgery here. And so one thing that the software also does, and you can see that on the right of the screen, it gives you the reference values and compares the measurements of your patients to the reference values. So oftentimes you can see dysplasia and impingement at the same time. So that will help you with planning. If you go in and thinking this is just an impingement problem, you're going to resect too much and you can make a patient unstable, and that would obviously be not good for that patient, and it could lead to some bad stuff. And so it does this on the femoral side and the acetabular side as well. And so, finally, this is kind of what this looks like. On the left side there, you can see what the arthroscopic labor repair looks like. You typically make a little bit of a clearance on that contralabral junction. The anchor is put in, and then this is just using a suture pass where you kind of go around the labrum and just tack it down. You can do that in a mattress fashion or just kind of all around the labrum as such. Biomechanically, the mattress configuration is better. However, clinically, I don't think it makes a big difference. And you just kind of go around the clock and you address the remainder of the labrum tear, debride the loose ends there, and that kind of, you can see what that looks like. And then the one in the middle there, that's what the shaving of the KM deformity looks like, and we use fluoroscopy intraoperatively to evaluate this, and there's also a software that also comes from Stryker, and they're not paying me for this, but it's a very, very useful tool to have in the operating room. So, and all the way to the right is an actual capsular closure, which is maybe the most critical part of the whole procedure, because we used to not repair the capsule, and patients did not do well. They would rapidly deteriorate and progress to arthritis and on the way to total hips. But what this does is it recreates that capsule, and it recreates the iliofemoral ligament, which is the most important stabilizer of the hip, especially in that external rotation. So before and after, cam on the left, no cam on the right. Thank you, guys.